Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about structure and function of the skin. The skin is a large organ weighing an average of 4 kg and covering an area of 2 meters square. Key points. The major function of the skin is to act as a barrier to maintain internal homeostasis. The epidermis is the major barrier of the skin. Components of skin include epidermis, dermis, and subcutaneous fat. Epidermis. The epidermis is divided into 4 layers. Layer in ascending order: basal cell, stratum spinosum, stratum granulosum, and stratum corneum. As we can see here, we can see basal cell layer, stratum spinosum, stratum granulosum, and stratum corneum. There is another layer between stratum granulosum and stratum corneum, which called stratum lucidum. Here we can see the stratum lucidum between the stratum corneum and stratum granulosum. Structure: basal cell layer. We are going to talk about this layer or basal cell layer. The basal cells are the undifferentiated proliferating cells. Skin stem cells are located in the basal layer in the interfollicular epidermis, and they give rise to keratinocytes. For normal skin homeostasis, daughter cells from the basal cell layer migrate upward and begin the process of differentiation. In normal skin, cell division does not take place above the basal cell layer. The cell divisions happen in basal cell layer, and in normal skin, cell division does not happen above this layer. Does not happen in stratum spinosum or stratum granulosum. It's usually happen in basal cell layer. It takes about 2 weeks for the cells to migrate from the basal cell layer to the top of the granular cell layer, and a further 2 weeks for the cells to cross the stratum corneum to the surface where they finally are shed. It takes 2 weeks for the cells to migrate from basal cell layers to the top of the stratum corneum, stratum granulosum or stratum lucidum, and a further 2 weeks to migrate from the top of the stratum granulosum to stratum corneum layer. Injury and inflammation increase the rate of proliferation and maturation, as illustrated by the increased epidermal thickness and transit time in lesions of psoriasis. In psoriasis, the time of proliferation and maturation is increased. Also, the time of the transit time of the cells in increased. Psoriasis, an autoinflammatory disorder characterized by thickened epidermis and increased scale. The second layer of the epidermis is stratum spinosum. We are going to talk about this layer, stratum spinosum, or here this layer, stratum spinosum. The stratum spinosum lies above the basal layer and is composed of keratinocytes, which differentiate from the basal cells beneath them. The keratinocyte produce keratin, a fibrous protein that is the major component of the horny stratum corneum. The stratum spinosum derives its name from the spines or intercellular bridges that extend between keratinocytes and are visible with light microscopy. Ultrastructurally, these are composed of desmosums, which are extensions from keratin within the keratinocyte. Functionally, they hold the cells together. As we can see, the name of stratum spinosum is taken from these connections between the keratinocytes, or we call them desmosums. Here we can see also that connections between the keratinocytes. Autoantibodies to desmoglein 3, a protein in the desmosome, result in the loss of cohesion between keratinocytes, bulla formation, and erosions as seen in pemphigus vulgaris. Here we can see the lesions and erosions or patient with pemphigus vulgaris. Pemphigus vulgaris, an autoimmune blistering disease wherein antibodies directed against desmosomes result in keratinocyte separation in stratum spinosum. The pathology of pemphigus vulgaris happens in stratum spinosum due to the autoantibody against desmoglein 3, and which results to their separation of the keratinocytes in stratum spinosum. And the third layer of the epidermis is stratum granulosum. The process of differentiation continues in the stratum granulosum or granular cell layer, in which the cells acquire additional keratin and become more flattened. In addition, they contain distinctive dark granules seen easily on light microscopy that are composed of keratohyalin. Keratohyalin contains two proteins, one of which is called profilagrin, the precursor of filagrin. As its name suggests, filagrin plays an important role in the aggregation of keratin filaments in the stratum corneum. The other protein is called involucrin, from the Latin for envelope, that plays a role in the formation of the cell envelope of cells in the stratum corneum. Ichthyosis vulgaris, ichthys, which is derived from a Greek, is called fish, is an inherited dry skin condition secondary to deficient filagrin production, as noted on light microscopy or skin biopsy by a reduced or absent granular layer. Here we can see fishy skin in the patient with ichthyosis vulgaris. Ichthyosis vulgaris, a loss of function filagrin gene mutation causing a generalized dry skin condition, not fish-like scale on the anterior shin. We can see this pathology happens in the stratum granulosum, or in this layer. Okay. Granular cells also contain lamellar granules, which are visualized with electron microscopy. Lamellar granules contain polysaccharides, glycoproteins, and lipids that extrude into the intercellular space and ultimately are thought to help form the cement that holds together the stratum corneum cells. Degradative enzymes also are found within the granular cells. These are responsible for the eventual destruction of cell nuclei and intracytoplasmic organelles. Point granular cells contain keratohyalin and lamellar granules. The fourth layer of epidermis is stratum corneum. A remarkably abrupt transition occurs between the viable nucleated cells at the top of the granular cell layer and the dead cells of the stratum corneum. The cells in the stratum corneum are larger, flat, polyhedral plate-like envelopes filled with keratin. They are stacked in the vertical layers that range in thickness from 15 to 25 layers on most body surface, to as many as 100 layers on the palms and soles. These cells are held together by a lipid-rich cement in a fashion similar to bricks and mortar. The tightly packed keratinized envelopes in the stratum corneum provide a semi-impenetrable layer that constitutes the major physical barrier of the skin. Note, the stratum corneum is the major physical barrier. Note, the skin microbiome could be considered another outermost layer of the epidermis. It plays an active role in modulating the host's immune response to pathogen, and it's very important. The skin microbiome is another outermost layer of the epidermis. Other cellular components, in addition to basal cells and keratinocytes, three other cells are located in the epidermis, like melanocytes, Langerhans cells, and Merkel cells. Melanocytes, as we can see, we have melanocytes in stratum. We have melanocytes in Stratum basalis, we have melanocytes in stratum basalis, we have Merkel cells in stratum basalis, and Langerhans cells in stratum spinosum. Okay. Melanocytes are dendritic pigment producing cells located in the basal cell layer. They protect the skin from ultraviolet radiation. Individuals with little or no pigment develop marked sun damage and numerous skin cancers, as we can see in the patients with albinism. The dendrites extend into the stratum spinosum and serve as conduits through which pigment granules are transferred to the neighboring keratinocytes. The granules are termed melanosomes, and the pigment within the melanin, which is synthesized from tyrosine. Melanosomes are preferentially situated above their nucleus to protect the DNA. People of all races have a similar number of melanocytes, and this is important. In dark-skinned and light-skinned people, the number of melanocytes is similar or equal. The difference in skin pigmentation depends on, first, the number and size of the melanosomes, and second, their dispersion in their skin, or it's the number and size of melanosomes which is different in different people with different skin color. In darkly pigmented skin, melanosomes are darker, larger in size, and more numerous compared with melanosomes in lightly pigmented skin. Sunlight stimulates melanocytes to increase pigment production and disperse their melanosomes more widely. Difference in skin color is due to the size, number, pigmentation, and dispersion of melanosomes. Langerhans cells. Langerhans cells are dendritic cells in the epidermis that have an immunologic function. They are derived from the bone marrow and constitute about 5% of the cells within their epidermis. On electron microscopic examination, characteristic tennis racket-shaped granules are seen. Langerhans cells are identical to tissue macrophage and present antigens to lymphocytes, with which they interact through specific surface receptors. As such, Langerhans cells are important components of the immunologic barrier of the skin. Point: Langerhans cells are the first line of immunologic defense in their skin. Merkel cells. Merkel cells are located in the basal cell layer. They are more numerous on the palms and soles and are connected to keratinocytes by desmosomes. Merkel cells function as mechanoreceptors. And dermal-epidermal junction. The basement membrane zone. The interface between the epidermis and dermis is called the basement membrane zone. With light microscopy, it is visualized only as a fine line. However, electron microscopic examination reveals four regions: keratin filaments in the basal keratinocytes attached to hemidesmosomes, electron-dense units, which in turn attach to anchoring filaments in the lamina lucida. The lamina lucida is a relatively clear lucid zone traversed by delicate anchoring filaments that connect hemidesmosomes of basal cells to their lamina densa. The lamina densa is an electron-dense zone composed primarily of type 4 collagen, derived from epidermal cells and anchoring fibrils, which are thick fibrous strands composed of type 7 collagen and located in the sublaminar denser region of their papillary dermis. The basement membrane zone serves as the glue between the epidermis and dermis and is the site of blister formation in some bullous disease. As we can see here, the diagnosis here, we have a patient with bullous pemphigoid. The most common autoimmune blistering disease in the elderly secondary to immune disruption of their hemidesmosome. Key points about epidermis. Keratinocytes are the principal cells of the epidermis. Layers in ascending order: basal cell, stratum spinosum, stratum granulosum, and stratum corneum. Basal cells are undifferentiated proliferating cells. Stratum spinosum contains keratinocytes connected by desmosomes. Keratohyalin granules are seen in the stratum granulosum. Stratum corneum is the major physical barrier. The number and size of melanosomes, not melanocytes, determine the skin color. Langerhans cells are derived from bone marrow and are the skin's first line of immunologic defense. The basement membrane zone is the substrate for attachment of the epidermis to the dermis. The four major ultrastructural regions of the basement membrane zone include the hemidesmosomal plaque of the basal keratinocyte, lamina lucida, lamina densa, and anchoring fibrils located in the sublamina densa region of the papillary dermis. In conclusion, as we can see here, in epidermis we have basal cell layer. In basal cell layer we have melanocytes and Merkel cells and primary cell skin cells, and we have stratum spinosum. In stratum spinosum we have keratinocytes also, and Langerhans cells, and stratum granulosum we have cells filled with granules, and stratum corneum, which is their first layer of the skin from descending to ascending side. Dermis. The dermis is a tough but elastic support structure that contains blood vessels, nerves, and cutaneous appendages. It provides structural integrity and is biologically active by interacting and regulating the functions of cells, example, tissue regeneration. The dermis ranges in thickness from 1 to 4 mm, making it much thicker than the epidermis, which in most areas is only about as thick as a piece of paper. The dermal matrix is composed primarily of collagen fibers, principal component, elastic fibers, and ground substance or extrafibrillar matrix, which are synthesized by dermal fibroblast. Dermal fibroblast is important in systemic scleroderma. Here we have the patient with systemic scleroderma. Systemic scleroderma, an increase in the number and activity of fibroblast produces excessive collagen and result in dermal thickening. In touch, we can feel the thickening and hardening of the skin due to their collagen deposition beneath the skin, due to their to the increase in the number and activity of fibroblasts, which leads to the to excessive produce of collagen fibers. Collagen accounts for 70% of the dry weight of skin. Collagen and elastic fibers are fibrous proteins that form the strong yet compliant skeletal matrix. In the uppermost part of the dermis or papillary dermis, collagen fibers are fine and loosely arranged, and in the remainder of the dermis or reticular dermis, the fibers are thick and densely packed. This histology is showing their skin structure. Here we have their epidermis, and here we have the dermis. As we can see, the dermis is much more thicker than the epidermis. In epidermis, as we said, we have papillary dermis and reticular dermis. In papillary dermis, we have fine, loose collagen strands, and in reticular dermis, we have thick and dense collagen strands. Elastic fibers are located primarily in the reticular dermis, where they are thinner and more loosely arranged than collagen fibers. The extrafibrillar matrix fills the space between fibers. It is a non-fibrous material made up of several different mucopolysaccharides molecules, collectively called proteoglycans or glycosaminoglycans. The extrafibrillar matrix imparts to the dermis a more liquid quality, which facilitates movement of fluids, molecules, and inflammatory cells. Key points: dermis provides structural integrity and is biologically active. The primary components of the dermal matrix are collagen, elastin, and extrafibrillar matrix. Collagen, the principal component of the dermis, represents 70% of skin's dry weight, and structural components of the dermis include collagen, elastic fibers, and extrafibrillar matrix. Nerves and blood vessels course through the dermis, and a layer or subcutaneous fat lies below it. As we can see here, we can see the nerve and blood vessels with air course through the dermis, and subcutaneous fat or hypodermis is beneath them. Nerves. The skin is a major sensory receptor. Without the sensation of touch, temperature, itch, and pain, life would be less interesting and more hazardous. Sensations are detected in the skin by both free nerve endings and more complicated receptors that are corpuscular in structure. The free nerve endings are more widespread and appear to be more important. Free nerve endings are the most important sensory receptor. The nerve supply of the skin is segmental, dermatomal, with considerable overlap between segments. In herpes zoster, as we can see here, we can see the blisters and erosions of herpes zoster virus. Reactivation of varicella zoster virus in sensory nerve ganglia results in painful vesicular dermatomal eruptions, and this is due to the dermatomal innervation of their skin, segmental or dermatomal innervation of their skin. Blood vessels. The blood vessels in the skin serve two functions: nutrition and temperature regulation. The epidermis has no intrinsic blood supply, and therefore depends on the diffusion of nutrients and oxygen from vessels in the papillary dermis. Blood vessels in the dermis also supply their connective tissue and appendageal structures located therein. Functions of blood vessels: first, to supply nutrition, and second, to regulate temperature. The vasculature of the skin is arranged into two horizontal plexuses that are interconnected. The superficial plexus is located in the lower border of the papillary dermis, and the deep plexus is located in the reticular dermis. Temperature regulation is achieved through shunts between the plexuses. Increased blood flow in the superficial plexus permits heat loss, whereas shunting of blood to the deep plexus conserves heat. As we can see here, we have two plexuses of blood vessels in the dermis: the deep arteriovenous plexus and the superficial arteriovenous plexus. The shifting of blood to the superficial arteriovenous plexus, which is located in the papillary dermis, leads to the heat loss, and the shift of the blood from superficial to the deep arteriovenous plexus leads to serve the heat. And the deep arteriovenous plexus is located in the reticular dermis. Skin appendage. The skin appendage are the eccrine and apocrine sweat glands, hair follicles, sebaceous glands, sebaceous glands, and nails. Eccrine sweat glands for physical activity, active individuals, and for people living in hot climates. The eccrine sweat glands are physiologically the most important skin appendage, providing thermoregulation. They are activated by emotional and thermal stimuli. Cholinergic innervation is responsible for physiologic eccrine secretion. Botulinum toxin type A, or Botox, injected intradermally, or glycopyrrolate orally, can treat hyperhidrosis by blocking acetylcholine action. Eccrine sweat glands help to regulate body temperature by excreting sweat onto the surface of the skin, from which the cooling process of evaporation takes place. 2 to 3 million eccrine sweat glands are distributed over the entire body surface, with a totally secretory capacity of 10 liters of sweat per day. The secretory portion of the sweat apparatus is a coiled tubule located deep in the dermis. The sweat is transported through the dermis by a sweat duct, which ultimately twists a path through the epidermis. As we can see here, the acrine sweat gland, we can see the acrine sweat gland, and the secretory part of the sweat gland is located deep in the dermis, and we have the duct of the sweat gland, and here finally it twists through the epidermis. The sweat is in the secretory part of acrine sweat gland is isotonic with their serum, but in their collective duct the electrolyte is absorbed, and the sweat is, when the sweat is coming through their sweat gland on their stratum corneum layer is hypotonic. Is due to the reabsorption of sweat in their sweat duct. The action of the mechanism is action of sweat glands is like as collecting tubules in the kidney. Sweat secreted in the glandular portion is isotonic to plasma, but becomes hypotonic by the time it exits the skin as a result of ductal reabsorption of electrolytes, as we explained. Acrine sweat glands help to regulate temperature and are under cholinergic innervation. Apocrine sweat glands. We are going to talk about apocrine sweat glands. In humans, apocrine sweat glands are androgen dependent for their development and serve no known useful function. Although they are responsible for body odor, the odor actually results from the action of surface skin bacteria on excreted apocrine sweat, which itself is odorless. Apocrine sweat glands are located mainly in the axillary and anogenital areas. The secretory segment of an apocrine gland is also a coiled tubule located deep in the dermis. However, unlike in acrine glands, in which the secretory cells remain intact, in apocrine glands the secretory cells decapitate their luminal or apical portions as part of the secretory product. The apocrine duct then drains the secreted sweat into the mid portion of a hair follicle, from which it ultimately reaches the skin surface. As we said, the acrine sweat glands directly excrete the sweat to the surface of the skin, but apocrine sweat glands connected to the mid portion of the hair follicle, and they secrete the sweat to the hair follicle, and from hair follicle the sweat reach the surface of their skin. Note: bacterial action on apocrine sweat causes a body odor. The sweat by itself is odorless. Hair follicle. In most mammals, hair serves a protective function, but in humans it is mainly decorative. Hair follicles are distributed over the entire body surface except the palms and soles. Hair comes in two sizes: vellus hairs, which are short, fine, light colored and barely noticeable, and terminal hairs, which are thicker, longer and darker than the vellus type. Terminal hairs in some locations are hormonally influenced and do not appear until puberty. Example: beard hair in males and pubic and axillary hair in both sexes. Types of hair, as we said: vellus or light and fine, and terminal dark and thick. A hair follicle can be viewed as a specialized invagination of the epidermis with a population of cells at the bottom, hair bulbs that are replacing even more actively than the normal epidermis basal cells. As we said, the hair follicle is usually an invagination of the epidermis, and the cells of the hair follicle the cells of hair follicle are more active than the cells in the epidermis layer. These cells constitute the hair matrix. As with basal cells in the epidermis, the matrix cells first divide and then differentiate, ultimately forming a keratinous hair shaft. Melanocytes in the matrix contribute pigment, the amount of which determines the color of the hair. As the matrix cells continue to divide, hair is pushed out and exits through the epidermis at a rate of about 1 centimeter per month. As we can see here, this histology is showing the hair follicle. We have here hair cuticle, cortex, medulla, and so on. Hair growth in an individual follicle is cyclical, with growth, anagen phase, a transitional catagen phase, and resting or telogen phase. The duration of the phases vary from one area of the body to another. On the scalp, for example, the anagen phase lasts for about 3 years, the catagen phase for about 3 weeks, and the telogen phase for about 3 months. The duration of the anagen phase varies from individual to individual, explaining why some persons can grow hair longer than others. Hair growth cycles through growth, anagen, transitional catagen, and resting telogen phase. As we said, there growth phase or anagen is 3 years, the transitional or catagen phase is 3 weeks, and a resting or telogen phase is 3 months. At the end of the anagen phase, growth stops and the hair follicle enters the catagen and telogen phase, during which the matrix portion and lower 2/3 of the hair follicle shrivels and the hair within the follicle is shed. Subsequently, through mesenchymal interaction with the hair follicles, stem cells, a new hair matrix is formed at the bottom of the follicle, and the cycle is repeated. At any time, 80 to 90% of scalp hair is in the anagen phase and 10 to 20% in the telogen phase, thus accounting for a normal shedding rate of 25 to 100 hairs per day. Okay, losing 20 to 25 to 100 hairs per day of scalp hair is normal. Alopecia areata is an autoimmune condition resulting in non-scarring circular patches, or alopecia is due to their immune system attack to the hair follicles, which leads to their temporary hair loss. Normally, 25 to 100 hairs are shed from the scalp each day. Layers of skin, as we said, the 3 layers of skin are the epidermis, dermis, and hypodermis. We can see the structure of the skins, we can see their skin appendage, and so on. The hair follicle is situated in the dermis at an angle. As we can see here, the hair follicle is situated in the dermis at an angle, attached to the arrector pili muscle, and we can see the arrector pili muscle, which is attached to hair follicle. The hair is arrector pili muscle. When this muscle contracts, the hair is brought into a vertical position, giving a goose flesh appearance to the skin. The stem cells of the hair follicle are located in the bulge area of the follicle, where the arrector pili muscle inserts into the hair follicle and in the dermal papilla. The stem cells are important for reconstituting the non-permanent portion of the cycling hair follicle and play a role in reconstituting their epidermal cells. Sebaceous glands. Sebaceous glands produce an oily substance termed sebum, the function of which provides lubrication, hydration, and innate immunity. However, the skin of children and their palmar and plantar skin of adults function well without sebum. Sebaceous glands are part of the pilosebaceous unit and so are found wherever hair follicles are located. In addition, ectopic sebaceous glands are often found on mucous membranes, where they may form small yellow papules called forest spots. In the skin, sebaceous glands are most prominent on the scalp and face and are moderately prominent on the upper trunk. The size and secretory activity of these glands are under androgen control. The sebaceous glands in newborns are enlarged owing to maternal hormones, but within months the glands shrink. As we can see here, we can see infantile acne a common disorder affecting the pilosebaceous unit and maternal androgen are influential in this condition. They enlarge again in pre-adolescence from stimulation by adrenal androgens and reach full size at puberty when gonadal androgens are produced. Sebaceous glands are androgen dependent. The lipid-laden cells in the sebaceous glands are wholly secreted holocrine secretion to form sebum. Triglycerides compose the majority of the lipid found in sebaceous glands cells. From the sebaceous glands, sebum drains into the hair follicle, from which it exists on the surface of the skin. As we said, as the apocrine sweat glands, sebaceous glands also secrete their products to their hair follicle, mid portions of their hair follicle, and from there it exists onto the surface of their skin. Here we can see the sebaceous gland, which is secreting the contents into their hair follicle. Nails like hair are made of keratin, which is formed from a matrix of dividing epidermal cells. Nails, however, are hard and flat and light parallel to the skin surface. Located at the ends of fingers and toes, they facilitate fine grasping and pinching maneuvers. As we can see here, we can see the structure of the nail here. The proximal nail fold matrix, a nail plate, a nail bed, and hyponychium. Nail is made of keratin produced in the matrix. Usually this is the matrix of the nail, and the nail is produced from keratin here in nail matrix. The nail plate is a hard, translucent structure composed of keratin. It ranges in thickness from 0.3 to 0.65 millimeter. Fingernails grow at a continuous rate of about 0.1 millimeter per day, and toenails at a slightly slower rate. Four epithelial zones are associated with the nail. The proximal nail fold helps to protect the matrix. The stratum corneum produces forms the cuticle. The matrix produces the nail plate from its rapidly dividing keratinizing cells. Most of the matrix underlies the proximal nail fold, but on some digits, especially in the thumb, it extends under the nail plate, where it is grossly visible at the white lunula. The most proximal portion of the matrix forms the top of the nail plate. The most distal portion forms the bottom of the nail plate. Inflammation of the matrix is found in lichen planus, causes nail dystrophy. As we can see here, we can see nail dystrophy in patient with lichen planus. Lichen planus, an inflammatory condition that normally affects the skin and mucous membranes, but can affect the nail matrix and cause dystrophic nails. The epithelium of the nail bed produces a minimal amount of keratin, which becomes tightly adherent to the bottom of the nail plate. The pink color of a nail is due to the vascularity in the dermis of the nail bed. The epidermis of the hyponychium underlies the free distal edge of the nail plate. Stratum corneum produced there forms a cuticle to seal the junction of the distal nail bed and nail plate. Subcutaneous fat or hypodermis. A layer of subcutaneous fat lies between the dermis and the underlying fascia. It helps to insulate the body from cold, cushions deep tissues from blunt trauma, and serve as a reserve source of energy for their body. Biologically active fat cells play a role in hormone messaging, as evidenced by metabolic disturbances in obese children and adolescents with principal insulin resistance. Recent evidence supports the role of adipose-derived stem cells in wound healing. Hair follicles support growth and protection against photoaging. Within the subcutaneous fat layer, aggregates of fat cells or lipocytes are separated by fibrous septa that are traversed by blood vessels and nerves. Erythema nodosum is the result of subcutaneous inflammation concentrated in their fibrous septa. As we can see here, we can see erythema nodosum in this patient. And erythema nodosum, subcutaneous nodules, most commonly seen on skins of women after starting birth control pills, results from inflammation concentrated in the fibrosepta that separate the aggregated fat cells or lobules. As we can see here, erythema nodosum usually happens in fibrosepta. Okay, subcutaneous fat or hypodermis insulates, absorbs trauma, and is reserves energy source and is biologically active. Okay, this was a short explanation about the skin structure, which was include the dermis, epidermis, dermis, and hypodermis, and skin appendages. Thank you for your attention.